tonight.
The tremors were really bad. I couldn't grasp things.
She had the features of Parkinson's disease.
An ABC 27 special presentation.
With benign tremors, the minute you grasp something, that's when the tremors start. I gave up building models. I gave up working with my trains. Pete, you can't go on like this anymore.
Stimulating Minds, sponsored by Penn State Health Milton S. Hershey Medical Center.
Good evening, I'm Deborah Pinkerton. Michael J. Fox, Muhammad Ali, Linda Ronstadt are just a few celebrities living with Parkinson's disease. Approximately 60,000 Americans are diagnosed with Parkinson's each year, and it is estimated there may be up to 1 million Americans living with the disease. Another neurological condition that affects about 7 million people in the U.S. is essential tremor. So what is the difference between Parkinson's and essential tremor? What they do have in common is how they're treated. You will find out much more tonight. Now, if you have any questions at home, Amanda Peterson is here to tell you how to get them answered. Lebanon County man had to give up one of his greatest loves because his hand shook uncontrollably. Pete Uhlig had to make a big decision. Here's his journey.
I have boxes and cases and containers and filing cabinets filled with trains.
A true train collector. 71-year-old Pete Uhlig has been collecting trains since he was 6 years old.
And one of the first trains I had the opportunity to buy with my own money was a solid brass engine known as a Camelback.
Pete was in the process of building a train room when everything came to a screeching halt. His hands were the reason why.
HO trains are small, and if you want to put something together and take a small screwdriver and fit it into a screw, you can't do that. You're going like this.
Doctors diagnosed Pete with essential tremor, a neurological disorder.
An essential tremor tends to be a tremor with intention. They can't do anything that requires fine motor work. So simple things like, putting a key in a lock or trying to open a door. They can't get their hand to where they need it to be without it shaking all over the place.
Pete noticed similar symptoms when he was 8 years old.
We would go target practicing back in the woods. I would go with my father and sometimes my uncle. My uncle would say, "Pete, stop shaking." And I couldn't. And it wasn't that I was nervous, because I wasn't, but when I would sight the rifle, it would shake a little bit. My hands would shake.
A slight shake that didn't affect Pete for years.
Maybe in his 40s it got, a little bit more noticeable.
And it was only when I was manipulating something or picking something up that I would shake. Otherwise, you had no idea that that was a problem with me.
Initially, a neurologist treated Pete's symptoms.
They can be controlled with medication up to a certain point. And he said, then when you get to that point, he said, we'll have to have a talk about what's the next step. I was okay up until I was maybe in my late 50s. And then I could tell that it was starting to get worse.
Eating soup was an issue because, you had the little bit of liquid in your spoon, and if you weren't steady, you lost half of it before it got to your mouth.
If I was getting a drink of water and there was a glass, I made sure that when I picked it up with my hand, I put my other hand underneath.
Pete's neurologist suggested surgery.
He said, look, Hershey Medical Center has a marvelous program in which they do DBS. I said, well, what the heck is DBS? He said, that's deep brain stimulation. I'm thinking, a brain operation, great, that's what I need.
Pete was hesitant at first, but finally met with neurosurgeon Dr. Jim McInerney, who explained deep brain stimulation.
It sounds very, very detailed, and it is, but from the patient's perspective, when all is said and done, it's actually not a lot of recovery for most of them. It's not a lot of risk.
Naturally, I came home, talked to Nancy, and we discussed doing this, and I said, you know, this is a brain operation. I'm going to drill holes in my head. I said, you know, I'm not particularly comfortable with that.
It's understandable that people wouldn't jump right at the chance of having a brain operation. We get that, certainly.
Dr. McInerney said, you're going to know, when it's time to do something, when you finally get frustrated enough, it's, going to be your decision when you have this done.
Pete reached that point of frustration and agreed to have the surgery.
And I said, please explain to me exactly what you're going to do to me. And he said, look, Pete, it's 3 operations.
The first stage is to actually do the planning, to figure out where we think the target is and how we're going to get there safely. And to do that, we put in some screws that we can measure off of, and we get a CT scan that we can see everything on and measure.
He said, now you need to realize, Pete, that there is absolutely no sensation in your skull. You have no nerve endings, you have nothing else. All you're going to feel is where we are at the skin.
It didn't take very long at all, and when we left the hospital, he said, let's go to lunch. I'm there, okay.
A week later, Pete was back for the more in-depth operation.
Like any operation, when your loved one is, under anesthesia and, a surgeon is working on him, it's stressful, but it wasn't bad.
Well, I told him for the second operation we were going to put the wires actually to the targets, the things that we were going to stimulate that were going to make the tremors stop. Told him that he would be asleep at the beginning, but we would wake him up so that we could map out the function of the brain. We were going to listen to the electrical signals in the brain to firmly define his target. And when we were done with that mapping, we were going to put in the stimulating electrode and then turn it on and test it and make sure that it had the effect that we wanted, that it stopped his tremor, and also made sure that it didn't have any side effects.
So everything went fine and everything went perfectly.
There was no pain in my head. There was no internal pain in my brain that I could feel. It was fine.
We brought him back about a week later. We put him to sleep, general anesthetic, recovered the leads that we had left underneath the scalp, and then tunneled them down to his chest, where we made a little pocket to put the battery that was going to run everything.
A small battery that changed Pete's life.
I still to this day talk about that moment. They said, okay, now we're going to turn it on. And I'm thinking, okay, I can't wait to see how this really works. The test was a glass of water. Well, they said, okay, pick that up. Pick it up, and I'm going like this, shaking like that.
Then the technician turned the device on.
She said, okay, pick up the glass of water. Unbelievable. Like that, it's gone.
Yeah, it was just instantaneous. When they turned it on, it, just worked right off the bat.
No more tremors, no more restrictions for Pete.
It's nice to be able to pick something up and not be going like that. It's been perfect. For me anyway, it's been perfect. I have no complaints whatsoever.
Pete had the surgery 7 years ago. As you can see, he is doing great. Now joining us here in the studio, neurosurgeon Dr. Jim McInerney and neurologist Dr. Barbara O'Connell. Tell us, this surgery is truly amazing there in Pete's case. How long has deep brain stimulation been around?
Well, deep brain stimulation has been approved in this country since the late 90s, 1997, and we've been doing it at the medical centers since I got there in about 2004.
And Dr. O'Connell, how has this really helped your essential tremor patients?
It has been just amazing because people can go from not even being able to feed themselves. When you hit the right frequency, you just watch the tremor just melt away.
Okay, Dr. McInerney, Pete mentioned that you do have to be awake during a portion of the surgery. Talk to me about that. I mean, that's a scary situation.
It does sound that way. The good thing for us is that the brain doesn't have a center of pain. And so people can actually be awake and be comfortable during the operation. And it's a tremendous benefit for us because it allows us to test the device and make sure that it's working right and make sure that people aren't having side effects or any problems. So having them awake is a little bit unusual, but they do great, and it's very, very helpful.
And tell me, what are the risks involved with this?
So obviously, any operation has risks, bleeding and infection and things like that, but I think people worry most about their brain. How are they going to think and feel and everything that they did before. The good part about this is that we're going to a part of the brain that doesn't actually do thinking so much as it does moving. And the parts that we go through are sort of similar in that regard. And so people tolerate this remarkably well, and their recovery is usually pretty quick.
And Dr. O'Connell, why don't you tell us, after they have the surgery, how often do they see you then?
Well, during the first 2 months after the surgery, we see them more often, once a month, and just change the amperage in the current that is circulating by just a few tenths of a volt each time. Then as it becomes more established, then the visits and the tremors controlled, then the visits can be farther and farther apart, a few months at a time.
Okay, great.
So we have some of those questions here. We also have Dr. Nicholas Bradmeyer to answer some of these. You've been answering some emails. Have you seen a lot of emails tonight?
Yeah, absolutely.
Well, we thank you for being here for answering them. So we have a viewer question here. It says, can the deep brain stimulation procedure help stroke patients and patients that have seizure disorders?
Sure. So chiefly patients who have had a stroke that causes tremors can be helped the most currently with deep brain stimulation. Seizure disorder is an active area of research, but for right now, it's still a research application of the simulation only.
Okay, so right now, just the stroke patients would be the ones to get the most, and those symptoms being the tremors and everything like that. All right, thank you, Dr. Bradmeyer. We will get you back into the email center to answer some more viewer questions. Again, if you have a question, you can email him at questions@abc27.com. We'll send things back to you, Deborah.
Thanks, Amanda. Deep brain stimulation is used for patients with essential tremor and Parkinson's disease. Later in the show, we will find out what other conditions can be treated with DBS now and in the future. And up next, daily chores became impossible for this Parkinson's patient until she had deep brain stimulation. Stay with us. We will be right back.
You're watching Stimulating Minds on ABC 27, sponsored by Penn State Health Milton S. Hershey Medical Center.
Welcome back. Doctors diagnosed a Lebanon County woman with Parkinson's disease. Surgery took away her symptoms just like that. Here's Joyce Cox's journey. Some of the first signs of spring, the birds singing. Now it's easy for 67-year-old Joyce Cox to fill the bird feeders. But years ago, she had great difficulty.
If you try to, use the scoop to get the bird feed out, I'd spill half of it before I ever got to the feeder.
Doctors diagnosed Joyce with Parkinson's disease when she was 52 years old.
Parkinson's disease is a defect in motor movement, particularly the initiation of movement, that is caused by a reduction in the body's supply of dopamine, which is an important neurotransmitter in motor activity.
It affected my right side because it was like if I was washing the dishes, I would drop the dish or the glass with my right hand. And it was my right pinky finger that was, tremoring.
She would get up and she would have to stop before she could take a step because of stiffness in her leg. And then that was from the Parkinson's.
Neurologist Dr. Barbara O'Connell treated Joyce's symptoms with medication.
It's Cinemet. It's also called levodopa, which after it's ingested is turned into dopamine by the body. And that helps to increase the supply of that neurotransmitter to the brain.
Because of some side effects from the medication, Dr. O'Connell suggested surgery.
So she was somebody that came under consideration for the deep brain stimulation sooner than somebody would who had good tolerance for the medicine.
I was sort of leery about it at first. I wasn't, prepared to hear about the surgery.
It's a big step. Somebody's going to put a piece of metal in your brain, and so that's got to be your decision, and support whatever you decide to do.
Joyce decided to have the deep brain stimulation procedure.
I had the surgery, and I was amazed.
Oh, it was a world of difference. I mean, it was almost almost instantaneous.
It controlled the tremor. Her posture was better, her walking, and she was having less difficulty with just all of her activities of daily living.
Until 4 years later, Joyce developed tremors on the left side of her body.
The tremors were very bad. Like if I tried to, if my hair got in my face or something, I would go like this. Or, trying to put my makeup on in the morning, it was just impossible.
Parkinson's disease can start asymmetrically, meaning it can affect one side of the body much more than it affects another side. But generally, as the degeneration progresses, the other side will start to show symptoms as well. And that's what happened with Joyce.
Joyce met with neurosurgeon Dr. Jim McInerney.
Because she already had that experience, she was very interested in getting her other side taken care of. She knew there was a really good chance that we'd be able to make her better.
When she decided to have the second one done, I was, okay. I was all for it.
I had to come in one day. Dr. McInerney fastened the screws, the halo on.
So this is her preoperative scan. So what we're doing is we're looking for a spot in the frontal lobe to go in. So we've put 3 screws around that. Once we have all that, we're ready for the second stage where we're going to actually implant the electrodes. There, we're going to use all that targeting information that we had before, but we're going to combine it with the electrical recordings from the patient's brain itself so that we can confirm where those targets are. And we're going to test it while we're there. When we're happy with that, we're going to secure those leads so that they're there forever.
Joyce returned to the hospital a week later for the final stage.
We bring somebody back a little bit later when we do a general anesthesia procedure where we put somebody to sleep so that we can tunnel the wires under the skin to a pocket that we usually make in the chest where we put a little battery and computer that runs the whole thing. And we hook everything up, test it, make sure everything's working well, and that's it.
I saw her after the surgery to adjust the stimulators. You can change a variety of things, but in general, most often what you are changing is the amperage, the voltage, which determines the strength of the current that is being put into the brain that can suppress these symptoms.
I noticed a difference. I mean, there was no more tremors, or I wasn't dropping things. I could walk better. Just a great 100% difference.
A procedure that makes every day memorable for Joyce.
Everybody dreams about retirement and traveling and not having worries. And with these 2 operations she's had, we don't have the worries. And we can travel and we can do what we want to do.
It's just wonderful. It really is, Being able to travel and just go to town and talk to people and go to lunch with my friends, and I'm just very grateful and thankful.
And what a difference this procedure has made for Joyce. Dr. O'Connell, what are the symptoms of Parkinson's disease?
Many times people will first notice a tremor, although not everyone does, but nearly everyone will notice more slowness of their movement, more rigidity in their muscles, making it more difficult to get around and to do the things they did before much more slowly. Later on in the disease, they can have more problems with balance and with walking.
And how do these symptoms differ for essential tremor patients?
In essential tremor, the tremor generally surfaces when someone is trying to do something. If, for example, if you're trying to reach for something, the closer patients get to the target, the worse the tremor becomes, and they may knock over what they're looking for. Or in the case of Parkinson's disease, the tremor is a resting tremor. And generally when the patients start to move, then the tremor will begin to diminish.
Okay. Dr. McInerney, how does this help? How does DBS help Parkinson's patients?
Well, we're very good at getting rid of tremors, and for both essential tremor in Parkinson's patients, but most Parkinson's patients complain mostly of that stiffness and that slowness, and we're able to make those things melt away, and I think that's the thing that they notice the most.
Dr. O'Connell, when do you suggest DBS for your patients?
Most patients are controlled for a period of time with a medicine called Sinemet, which is actually changed by the body into dopamine, which is the transmitter that's missing in Parkinson's disease because that area of the brain has started to degenerate. But later on, what will happen is the medicine won't work quite as well. It doesn't kick in as fast as it used to. It won't last as long. And people can get what are called motor fluctuations, where all of a sudden they'll have a problem called freezing, where they just can't move. And once, it's important that Sinemet still work, because that's a very good sign that DBS will be successful. But the behavior of the Sinemet is just more erratic as far as controlling the symptoms.
Dr. McInerney, you have the device here that goes inside your chest. It's small. Tell me, how does this work as far as turning it on and off and also changing the battery?
Sure. Well, it's an electrical device, so it has to have power, and the power comes from the battery. And the battery, the patient has some control over the battery. They can turn it on and off and check it. A lot of times people will leave it on. Some people will turn it off occasionally. It is going to run out eventually and need to be changed, but it's a pretty small procedure to do that. And a lot of times we'll do that under local anesthetic, and just it's a same day kind of thing and pretty quick. So.
Okay, great. Dr. O'Connell, thank you for joining us tonight. And why don't we check in with the ABC 27 call center, Amanda?
Hi, Deborah. Yes, we have 2 more viewer questions for you. So we have Dr. Nicholas Brandmeier joining us again. Thank you for being here. So the first viewer question that we received says, I am only 52 and was diagnosed with Parkinson's a few years ago. My doctor has mentioned deep brain stimulation, but I'm still very active. If I got injured, could I still have an MRI?
Absolutely. So for the last several years and all going forward, all the deep brain stimulators we implant are MRI compatible from head to toe. So no limitations getting an MRI for quite a while.
Right, so an athlete might get injured, might need an MRI, that's not going to be an issue. Great. Our next viewer question comes from someone saying, my 87-year-old father was diagnosed with Parkinson's 6 years ago. He doesn't have tremors, but he's very weak. Is DBS an option for him?
Absolutely. So most of the symptoms that DBS treats in Parkinson's disease is not tremors. Includes things like stiffness, slowness of movement, difficulty starting a movement, and medication side effects and lowering your medication dose. So all of those things would be helped even if the patient doesn't have tremor.
Excellent. Thank you so much for being with us tonight and for answering all the viewer questions. We want to thank our specialists in the call center because they have been really hard at work tonight answering all these viewer questions, and we're going to send things back to Deborah.
Thanks, Amanda. Dr. McInerney, so we know that DBS works for Parkinson's, essential tremor. What about other neurological disorders?
So it is FDA approved for dystonia, which are sort of focal motor contractions, and obsessive compulsive disorder too, actually. And it is being actively researched for things like epilepsy, which is actually done in Europe. It's been looked at for Alzheimer's disease and addictive behaviors, obesity. So there's an awful lot of things going on, and hopefully we're going to be able to use this tool for much more as time goes by.
And talk to us about who is eligible for this. Do you have to wait a certain amount of time?
Well, in general, with Parkinson's patients, we sort of go by a rule of thumb that, diagnosed for about 4 years, motor fluctuations for about 4 months, like Dr. O'Connell was talking about. For essential tremor patients, it's really how bad is the tremor? Is it interfering with your life? Has it gotten to the point that medications aren't taking care of it? And then, we evaluate people and come to those decisions with them.
And what about insurance coverage? Is this a hard thing to get over?
No, it actually isn't hard to get covered at all. It's a dramatic procedure, a dramatic effect, and I don't think anybody has any trouble paying for that. So we haven't had any difficulty with that.
And how is it when you see the patients after they had this done?
It is truly a remarkable thing. I mean, I really and truly feel blessed to be able to do something like this. It is, there is nothing quite like the feeling of seeing somebody come back and being able to do things they haven't been able to do for years. It's really special.
Okay, Dr. McInerney, thank you for joining us this evening.